Axial muscles have both their origins and insertions on parts of the axial skeleton, and so the axial muscles help to support and move the head and spinal column, function in non-verbal communication by affecting facial features, move the lower jaw during chewing, assist in food processing and swallowing, aid in breathing, support and protect the abdominal and pelvic organs. The axial muscles are arranged into 5 groups: muscles of the head and neck, muscles of the vertebral column, muscles of respiration, muscles of the abdominal wall, and muscles of the pelvic floor. In addition to just the sheer anatomy of where these muscles are located, you will also be responsible for the name, the location, action and origin, as well as the insertion of these muscles. So we'll begin with the muscles of facial expression, where they have their origins in a superficial fascia or on the skull bones, and these muscles insert into the superficial fascia of the skin, so when they contract, they contort the skin and cause it to move. The epicranius is composed of the occipital frontalis muscle, which are divided by the gallia aponeurotica, or the epicranial aponeuroses. The frontal belly of the occipital frontalis is superficial to the frontal bone of the forehead. When this muscle contracts, it raises the eyebrows and wrinkles the skin of the forehead, and thus the insertion is the skin above the nose and the eyes. The occipital belly of the occipital frontalis covers the posterior side of the head, and when this muscle contracts, it retracts the scalp slightly. And so the origin for this one then is the occipital bone. The Orbicularis Oculi consists of circular muscle fibers that surround the orbit. When this muscle contracts, the eyelids close, as when you wink, blink, or squint. And so the origin is the medial and orbital margin and the lacrimal sac, and it inserts into the lateral cheek skin. The Orbicularis Oris is composed of muscle fibers that encircle the opening of the mouth. And so these also have a circular arrangement of their muscle fibers. When this muscle contracts, you close your mouth, and when you pucker up for a kiss, you're using these muscles. So the origin is the skin of the lips near the midline, and the insertion is also the skin of the lips. The depressor labii inferioris pulls the lips down inferiorly. So the origin for this muscle is the anterior surface of the mandible, and it inserts on the skin of the lower lip. The depressor anguli oris pulls the corners of the mouth inferiorly, and so this is considered our frowning muscle. The origin is the oblique line of the mandible, and the insertion is the angle of the mouth. The levator labii superioris pulls the upper lip superiorly, and this is used when a person is sneering or snarling. The origin is the inferior margin of the orbit, and it inserts at the skin of the upper lip. The levator anguli oris pulls the corners of the mouth superiorly and laterally, and so this is considered our smiling muscle. And the origin is the anterior surface of the maxilla bone, and the insertion is the corner of the mouth. The zygomaticus are actually composed of a zygomaticus major and a zygomaticus minor. However, for our class, we'll just group them together as the zygomaticus muscles. And so these muscles work with the levator anguli oris muscles and also are considered the smiling muscles. They originate on the zygomatic bone, and they insert on the skin of the upper lip and lateral part of the upper lip as well. The risorius muscle pulls the corners of the lips laterally, and so you use this muscle when you make a closed mouth smile or a grinning. This is considered our grinning muscles. And so this originates on the fascia of the lateral cheek, and it inserts on the skin at the corners of the mouth. The mentalis attaches to the lower lip, and when it contracts, it protrudes the lower lip. And so this is considered our pouting muscle, where it originates on the anterior surface of the mandible and it inserts on the skin of the cheek. The platysma tenses the skin of the neck and lowers the lower lip inferiorly. And so this is a muscle that you can actually see in the mirror by yourselves when you tense the skin of your neck, and you can see the thin muscle that bulges out, and so that's your platysma. And so this originates on the skin over the lower neck and upper lateral chest, and it inserts in the inferior border of the mandible and the skin of the lower face. The muscles for mastication, or chewing, move the mandible at the temporomandibular joint. The buccinator compresses the cheek against the teeth when we chew, and so is one reason why our cheeks don't bulge out like squirrels or chipmunks when we eat. This is a muscle very important for infants as they suckle and drink, as well as for certain musicians such as trumpet players, where they allow their cheeks to be puffy with air when they play the trumpet by overstretching their buccinator muscle. So the origin of the buccinator is the mandible and the lateral maxilla, and the insertion is the angle of the mouth and lateral end of the upper and lower lips. The temporalis muscle is a broad, fan-shaped muscle that extends from the temporal lines of the skull and inserts on the coronoid process of the mandible. It elevates and retracts by pulling the mandible posteriorly. And so this is one that you can actually feel, so that when you chew, you can put your fingers along your temple, and when you open and close your mouth, that is the muscle you feel contracting. So the origin of the temporalis is the temporal fossa of the temporal bone, and it inserts at the coronoid process of the mandible and the ramus of the mandible. The masseter elevates and protracts the mandible by pulling the mandible anteriorly. It is the most powerful and important of the masticatory muscles, as this is a short and thick muscle that is superficial to the temporalis. And so you can also feel this muscle contracting when you palpate near the angle of the mandible as you open and close your mouth. The origin of this muscle is the zygomatic arch and the zygomatic bone, and the inserts on the ramus and the angle of the mandible. The medial pterygoid muscle arises from the pterygoid plate of the sphenoid bone and inserts on the mandible. This is responsible for protracting the mandible and moves it from side to side during chewing. And the medial pterygoid will be more medial compared to the lateral pterygoid muscle. So again, it originates on the pterygoid plate of the sphenoid bone, as well as the maxilla and palatine bones, and it inserts on the medial surface of the mandible. And so this is a synergist to the masseter and the temporalis muscle, which again, synergist means aids in these types of movements. The lateral pterygoid also is responsible for protracting the mandible and moving the mandible from side to side during chewing. And so this originates from the greater wing of the sphenoid, and this inserts on the temporomandibular joint. Again, this will be more lateral in comparison to the medial pterygoid muscle. The muscles of the anterior neck are divided into the suprahyoid muscles, which are superior to the hyoid bone, and the infrahyoid muscles, which are inferior to the hyoid bone. And so for these muscles, you do not have to know their origin and insertion, because there are several muscles that make up the suprahyoid muscles and the infrahyoid muscles. So just focus on what are their general actions. And so for the suprahyoid muscles, these are associated with the floor of the mouth, and in general, these muscles act as a group to elevate the hyoid bone during swallowing or speaking. The infrahyoid muscles are contracting as swallowing ends, and this helps to influence the position of the hyoid bone and the larynx. In general, these muscles either depress the hyoid bone or depress the thyroid cartilage of the larynx. The muscles that move the head and neck include the sternocleidomastoid, which is a thick cord-like muscle that extends from the sternum and clavicle to the mastoid process posterior to the ear. Contraction of both sternocleidomastoid muscles flexes the neck, so that where we have contraction of just one sternocleidomastoid muscle, that results in lateral flexion of the neck and rotation of the head in the opposite direction. So, if the left sternocleidomastoid muscle contracts, it rotates the head to the right side of the body. The Erector Spinae muscles function to maintain posture and help an individual stand erect. And these are the muscles of the vertebral column. When the left and right erector spinae muscles contract together, they extend the vertebral column. If only one side of the erector spinae muscles contracts, then the vertebral column flexes laterally toward that same side. The erector spinae muscles are organized into three groups: the spinalis group, the longissimus group, and the iliocostalis group. These muscles share a common insertion of the angles of the ribs, the transverse and spinous process of the vertebrae, and the posterior aspect of the skull. They originate on the iliac crest, the sacrum, and the transverse and spinous process of the vertebrae. The diaphragm is the most important muscle for breathing. It is an internally placed dome-shaped muscle that forms a partition between the thoracic and the abdominal pelvic cavities. The muscle fibers of the diaphragm converge onto its margins towards a fibrous central tendon, which is a strong aponeurosis that is the insertion tendon for all the peripheral muscle fibers of the diaphragm. When the diaphragm contracts, the central tendon is pulled inferiorly toward the abdominal cavity, thus increasing the vertical dimensions of the thoracic cavity. As it compresses the abdominal cavity, it also increases the intra-abdominal pressure, and for such events necessary for urination, defecation, and for childbirth. The origin of the diaphragm is the xiphoid process and the inner aspect of the lower 6 ribs and lumbar 1 through 3 vertebral bodies. It inserts on the central tendon of the diaphragm, which is again an aponeurosis. With inhalation, we have contraction of the diaphragm, and this causes the diaphragm to move inferiorly. Thus, with exhalation, this causes relaxation of the diaphragm, and it moves superiorly towards the thoracic cavity. And so here's an image demonstrating the diaphragm and where the central tendon of the diaphragm is, where it is found along the midline of the diaphragm. And so again, with breathing in, with inhalation, what we have is that the chest expands, as well as the ribs, thoracic cavity, and then the diaphragm contracts and is pushed inferiorly. With exhalation, we have the chest cavity contracting, and the diaphragm can now relax, and then it is brought back superiorly towards the thoracic cavity. The other sets of the muscles of respiration include the internal and external intercostals. The internal intercostals lie deep to the external intercostals, and their muscle fibers are at right angles to the external intercostal muscles. The internal intercostal muscles depress the ribs, but only with forced exhalation. With normal exhalation, there is no active muscular effort by the internal intercostals. The origin of these muscles are in the upper borders of the ribs, and they insert on the lower borders of the ribs above them. Now, the external intercostals extend inferiorly and medially from the superior rib of the adjacent inferior rib. The external intercostals assist in expanding the thoracic cavity by elevating the ribs during inhalation. This movement is like lifting a bucket handle so that the rib, which is the bucket handle, is elevated then as its distance from the center of the bucket, the thorax increases. And so with contraction, the external intercostals increases the transverse dimensions of the thorax cavity during respiration. The origin of the external intercostals are the lower borders of the ribs within an intercostal space, and they insert on the upper border of the rib below them. Again, with breathing, the intercostals are responsible for inspiration and expiration, and they assist with this movement, where with inhalation and exhalation, we have both the external intercostals that are involved, whereas with the internal intercostal muscles, these are only involved with forced exhalation. And so the external intercostal muscles are superficial to the internal intercostal muscles. One way to also think of the difference between the two, since they do run perpendicular to one another, is that the external intercostals are like in the same direction as if you would put your hands in your pocket, and so these would run inferiorly and medially, whereas the internal intercostals would run in a push-up bra action, which is superior and medially. The muscles of the abdominal wall collectively compress and hold the abdominal organs in place, and these include the external oblique muscles, the internal oblique muscles, the Transversus Abdominis, and the Rectus Abdominis. And together they work to flex and stabilize the vertebral column as well. The external oblique muscles are going to be directed in an inferior and medial orientation. These are superficial and are muscles along the lateral abdominal wall that help to form an aponeurosis that projects anteriorly. The origin is the external surface of ribs 5 through 12, and it inserts on the iliac crest. And so when we have unilateral flexion of one side of these muscles, we have rotation of the vertebral column in the opposite direction. The internal oblique muscles are immediately deep to the external oblique muscles, and these fibers project in a superior and medial orientation that are at right angles to the external oblique muscles. The origin of the internal oblique muscles are the anterior iliac crest, and they insert on the costal cartilage of ribs 8 through 12. The action, just like with the external obliques again, is for flexion of the vertebral column, where we have rotation in the opposite direction of which the obliques have been contracting. And so here's an image where we have the external and the internal obliques that will be superficial and deep, respectively, to one another. The Transversus Abdominis is going to be the deepest muscle of the abdominal wall, and these fibers project transversely across the abdomen. It originates on ribs 6 through 12 on the anterior iliac crest. The insertion is the pubic symphysis and the xiphoid process. The action of the Transversus Abdominis is to help compress the abdominal contents, and also helps with forced expiration with breathing. The Rectus Abdominis is a long strap-like muscle that extends vertically for the entire length of the anterior and medial abdominal wall between the sternum and the pubic symphysis. When somebody has a toned abdominal wall, the Rectus Abdominis is responsible for giving that six-pack appearance. On the contrary, the Rectus Abdominis actually separates with pregnant women, and this will fuse back together with once the child is born. And so the origin is the pubis and the pubic symphysis of the Rectus Abdominis, and the insertion is the xiphoid process in the costal cartilage of ribs 5 through 7. And so what this does is it helps to depress the ribs and stabilize the pelvis while we walk, as well as for flexing the trunk.